And before I introduce the next panelist, I'd like us to bring insightful video about Rwanda's healthcare transformation. That was really an excellent introduction to the coming session on sustainable solution to decentralization of healthcare in Rwanda. So without further ado, let me invite Monica Sanders, whom I had introduced earlier, the Director of Global Citizenship. And Monica joined me on stage. And also with Monica, also Manasseh, who has been sharing his views with us. Welcome, Monica and Manasseh. I'd like to immediately hand over the session to you so that you can introduce yourself briefly and tell us more about Rwanda's universal healthcare ambitions, the re-emerging health post model, and also the collaboration between the Ministry of Rwanda, Ministry of Health in Rwanda, the Society of Health, and Abbott. Over to you.
Yeah, thank you so much, Rosemel. Once again for the welcome. I think the biggest and most bold approach for the government of Rwanda and collaboration with the Society for Family Health as a civil society and Abbott as a private sector actor is to go into enchanted waters and try to go boldly to unlock certain barriers to healthcare in Rwanda by the approach of decentralizing healthcare in terms of establishing these second-generation health posts. Like one of the previous speakers said, these health posts serve over 83% of the Rwandan population. And each of these in rural areas serves between 4,000 to 7,000 people, but on average, maybe 5,000. So really you can see that this is the core area of support if we must achieve universal health coverage. So basically, these health posts, we have seen tremendous results where I want to invite my colleague Monica probably to throw some light. Thank you very much, Rosemary.
Hey, good morning, Manasseh. It's good to see you.
Monica, welcome.
It's been a while since I've been with my buddies in Rwanda. My name is Monica Sanders. I am based in Chicago. I work for Abbott in our global citizenship group, and I focus on shared value projects. Manasseh and his whole team at SFH and I have become fast friends over the last year, and I will we're gonna, if you could start to queue up the presentation, I'm just gonna take a few more minutes just to talk in that I think that there was a couple of questions that came up earlier that mentioned about, you know, are we truly partnering? Are we engaging at the right level and at a sustained level? And I do believe that with this project, we are. And I hope that Manasseh agrees with me. I think sometimes he thinks I'm overly involved because I ask a lot of questions. But and I think that's how we all learn. and it's been a tremendous learning opportunity for me. So we're going to get started with the presentation. And Manasseh, why don't you kick it off, my friend?
Thank you. Thank you so much, Monica. I think on the screen you can see one of the health posts we have been describing. I think it came clearly through in the minister's speech earlier and also in Susan's address. This structure is a game changer, in my opinion, in terms of decentralizing healthcare and also in terms of enabling achievement of universal health coverage. Like I said earlier, if you look at on the screen, maybe the next
slide.
Next slide. On your screen, you can see that we're talking about enabling achievement of universal health care and improving access to primary health in Rwanda by, first of all, working on the biggest barrier, the distance. Later on in this presentation, I will be showing you what it means for a rural person in Rwanda to walk to a health facility. Remember, you walk to a health facility when you are sick or probably when you are feeling very bad. Even in an urban area, the culture of going to seek medical care is not up to the required level. In a rural area where people are fighting, are struggling to put food on the table, to raise school fees for children, it becomes even a secondary priority. Now imagine if you have to walk for 60 minutes to go and line up, it becomes a big problem. So what we have done with Abbott collaboration and the Ministry of Health and Society for Family Health is try to address this barrier. And like
Move to the next slide. Yeah, let's go to the next slide.
Yeah. By creating the solution, the magic, in my opinion, the game changer, the second generation health post. So with this slide, the public-private partnership really tries to address the issue of access. You can see on the right side of your screen, this partnership of Ministry of Health and the Abbott has enabled thousands of women to be able to have a place where they can have family planning, they can have ANC, and they can be able to also deliver. Maybe Monica, you want to talk about a few practical examples?
Yes. So yeah, we're gonna go through some of the actual client statistics here in a few minutes. But what's important to understand, I think, Manasseh, about this and to share with our audience is that that blue building that we see there is the culmination of almost 2 years of planning, understanding, and really working together to figure out what is really needed in the community. And so, you know, my colleague Susan Beverly talked earlier, who spoke earlier this morning. She was involved from this project in inception, and we sat down at the table and we looked at the needs, what was needed. And we developed really a needs-based, used a needs-based approach to come up with this design. Why don't we go to the next slide? And let's talk a little bit, Manasseh, about the design itself, how it's different from previous designs in the Health Post.
Yeah, thank you so much. And so maybe to give our audience a context, Rwanda's healthcare system is organized in a way that you start at a village level, where you talked about having 4 community health workers as the care providers. On top of the village, we have what we call a cell. That's the administrative structure. And in terms of health, that's where we have a health post. before we came up with this, like Monica just said, and what Susan alluded to earlier, where we took time to really organize and think about modifications and new design. We had what we call the first generation health post. Basically, the first generation health post did not have a lab, did not have maternity, but in terms of distance, it was so close, determined by the local people themselves to say we should place it here. So we looked at the needs, the gaps. We looked at the gaps within the first generation health post and realized that the issue of maternity, we did what we call patient care journey mapping. And it was very overwhelmingly clear that the citizens, the people in the community needed where they can have a lab. That's a facility where they will have confidence. And the women were, there was a loud voice, very clear and loud voice to have a maternity. So this design, this new second generation health post that you see on your screen has all that. It is a combination of the first generation health post and then the second generation health post. But also what we added was an excellent point of the patient flow. Because really, sometimes simple modifications, simple changes lead to enormous results. For example, the entry whereby when the patients come in, we put in a very large area where they can sit, relax, and feel comfortable and feel that they are cared for, they are attended to. And then we designed a big screen area where they have constant flow of information. I think in the previous session, we were talking about the role of communication, the critical component of communication. This second generation cares for that. Then the exit part of it is really very patient friendly. And then there comes the revolution of the lab with the Abbott supported ANC panel, which was 4 tests that are very rapid tests, I may say. And I wanted probably Monica to speak more about that. But really, it is, when I talked earlier about community-based, people-centered leadership and solution-oriented, this is a summary. This second generation design is a summary of people-centered, solution-oriented leadership that solves problems based on people's needs, which we really gathered from the patient journey mapping, where we talked to women, youth, younger kids, and the leadership to really see the problems and solve them. It is not a copy-paste. It is rather, it is need-based. Thank you.
Yeah. So just to quickly walk through, one of the big design changes is the include of a delivery suite. This suite is fully equipped to deliver, to help, to be there for a mother to deliver in a normal pregnancy. It also includes a private bath. The pharmacy is here, which is where clients can visit to pick up their prescriptions. It has a walk-up window in the covered reception area. This was a big response that we got from the community. Often while they're waiting for their appointments, clients had to sit under trees and oftentimes in the rain, and it was very uncomfortable. This whole seating area is covered. It also serves as an education space and vaccination day area when people from the health center come. 2 examination or consultation rooms, an observation room, and a dedicated wound care room with an automatic autoclave and for cleansing equipment and sterilizing bandages. If you go to the next slide, we'll talk about the innovation of Abbott in this situation. So one of the big concerns that we heard was around antenatal care. And as many of you are aware, there's a gap between the number of recommended antenatal visits that women in Africa receive and what is ideal. And because of that lack of visits, there isn't oftentimes all the testing that's done. What Abbott has innovated on is a all-in-one panel that includes 4 tests that deliver results on HIV, hepatitis, malaria, and syphilis in 25 minutes. We think that this is an important innovation here because it really helps towards the triple elimination of disease and pregnancy goals. It also facilitates compliance needs, and we think it ultimately should reduce the number of complications in pregnancy. So 4 tests in one, 25 minutes, 1 prick of the finger, and it's laid out in a neat workstation that's used in the lab along with the other equipment. I'm going to move to the next slide, please. We're gonna cue a video of it's called Eugenie's story, and it talks about one woman's actual. Yeah, go ahead.
Before you move to the next slide and the video, I think I wanted to invite our audience to kind of just think through, even in an urban setting, if you know that in about 10 to 15 minutes, you can be able to reach a health facility and you are able to get these 4 tests and you'll be in a comfortable environment, even in an urban area. But now imagine if you transfer that to a very rural setting and you are able to get this. I think to me it is quite revolutionary and it makes the changes and answers the earlier questions about is health transformation possible in Africa? What we are witnessing is a live example of what is possible if it is scaled up. Thank you.
Agreed. Thank you, Manasseh. So this next video tells you Eugenie's story.
I was scared. When you give birth without a doctor or healthcare provider, anything can go wrong. You can even die. For my last pregnancy, I went into labor in the evening. My neighbor came with me to the health center, but I didn't make it and gave birth at the side of the road. After giving birth, my neighbor helped me carry my baby to the health center. There were long lines. It was really tough. Thank God we reached there safely.
Second-generation health posts are so important because they provide a comprehensive nature of services. Malaria testing and treatment, we have HIV, we have family planning services, taking care of pregnant women. It is cutting distance. At least every household is 30 minutes walking distance. It is cutting financial hardships and it is increasing service delivery.
This health post is so close to us. It's really important. I don't have to walk long distances to antenatal checks. I can be there in 5 minutes.
So as you can see, 5 minutes, we're gonna go through some of the actual results and client statistics that we're seeing in the health post now. So let's move to the next slide. So, as Manasseh alluded to, we are very, very happy with what we're seeing. Through the month of April, we've seen 52,000 patients. We're averaging about 965 visitors or clients per month per health post. That ranges from about 700 up to 2,000, depending on which health post we're talking about. We've tested over 15,000, close to 16,000 people for malaria. We've resolved 3,800 positive cases. You see there almost 16,000 again cases of respiratory infections treated, intestinal parasites, and as Manasseh alluded to, over 560 antenatal visits and ANC panels completed with an average of 1.2 visits per mother. And one of the statistics that we are all most proud of is the healthy babies born right there in the community. To the next slide, please. So what you'll see is over time, as word spreads and people become more familiar with what's going on, we see a constant increase in the rate of participation from the local community. As we mentioned before, we're over 54,000 client visits since inception in October. And why you see the dip in April is because of the shelter-in-place requirements. Because of COVID, which has impacted everyone, we did see a slight dip in people coming to the health post as they stayed at home. Next slide, please. So, as we had mentioned before, ANC, antenatal care, is one of the new services that has been introduced to the second generation of health posts. And what you'll see here is that each month it depends on obviously where a mother is in her term of her pregnancy, but the high point was March, where 144 women came in and they received their antenatal visits and their tests. We're averaging about 1.1 or 1.2 visits per mother. Why this is important is because prior to this, a lot of women didn't actually receive an antenatal visit until well into their second or third trimester. And we're excited because over time, what we're seeing is that the average gestational age of the mother who's coming in for her first antenatal visit is declining, and we're getting more into what we would call clearly first trimester visits, which means we're going to have the opportunity to intervene sooner, and if there's any problems with the pregnancy, and bring a healthy baby to term. Next slide, please. Deliveries. We're happy to report over 240 babies delivered with minimal complications. To date, we've not seen any maternal mortality at birth, no infant or maternal mortality in a health post in the first 24 hours. These babies are big, bouncing, healthy babies, averaging about 3.2 kilograms, kilograms. Sorry, I'm American, so I'm used to pounds, so forgive me. If that's right, kilograms, right, Manasseh?
Yes.
Okay.
Yes, kilograms.
So
yeah,
that's about 7 or 8 pounds. That's a pretty healthy baby, in most terms. They're coming back for their postpartum visits. The early child visits are all taking place. And so we really see this as a win-win. Manasseh, any feedback that you can share from the community that you've seen so far about the health post and what's happening there?
Yeah, I think talking about the babies, one of the ways to put it into perspective is to imagine the absence of these health posts and these babies. What would have happened? From the video, we saw Eugenie talking about the distance she used to walk. And for ladies, walking when you are pregnant or when you are in labor, probably I might not be the best person to speak about it.
Right.
But definitely.
We'll give you a pass, Manasseh.
Yeah, but looking at these 200, to me, it is a joy of my heart because you can see transformation right before your eyes. Thank you.
Yeah. You know, I was actually there the week that the first babies were born, and I got to hold them. I should have put that picture in there. But the level of just happiness and excitement on the mothers' faces, that literally they were 10 minutes from home in many cases. What we're finding is that the average travel time of clients to the health post is about 17 minutes. Now, if you think about what the travel times that we've actually recorded to the health center, you measure it in hours. Okay, that's the, you know, again, we see a range of travel times anywhere from 5 minutes to 45 minutes, but the average travel time is 17 minutes. So, yeah.
The travel time is a walking time. It's not driving time. It's not a motorcycle riding.
That's right.
It's
That's right.
walking. Yeah.
Yeah. So what we did was we took a look at how second generation compares to first generation, and what we see is improvements on a number of metrics, including patient or client volume. We see that we're seeing at least 32% more patients or clients in second generation. We're having the opportunity to test and treat almost 200% more potential cases of malaria, 11% of respiratory infection, 100%, over 100% of intestinal parasites, and another metric which is very important to the government of Rwanda and the Ministry of Health is family planning. There's been a lot of research about how better spacing between pregnancies improves both the health and welfare of both mother and baby. And we've had significant numbers of women come in to seek consultation on planning their families better for the future. Next slide. So, next question is, this is all well and good, but what does this mean from a financial standpoint? What we can tell you is after 6 months of operation, we are seeing health posts that are in the black. They've been in the black since January. That means they're above zero in terms of their ability, their revenue intake exceeds their expenses. That's great news because this speaks to the sustainability of this effort that we put forth. And we see these health posts being able to continue to increase their sustainability and stabilize over time. Sorry, got a call there. But what we're probably running a little long on time, so let me speed it up a little bit. Yep, we got 2 minutes left. Here we go. So we're going to need to speed it up a little bit. What's important to note here, as many have mentioned before, is that really where we are seeking help is in improving the cycle time on reimbursement. In many countries, long cycle times with reimbursement for the government cause some cash flow challenges, but we know that the government of Rwanda has acknowledged this and is working very, very hard to improve this. And we expect that with this improvement, we're going to have a closed loop ecosystem that we're able to operate. Next slide. All right, so next slide. This is just, we're going to talk about how we're measuring long term. What I want to say is, in addition to the statistical data that we showed you real time, we have made the investment in commissioning a health economics research study that's really going to focus on the expected patient outcome improvements to quality of life measures and cost savings, which should impact and help us improve the overall healthcare system. Next slide. So this is what we're looking at. We're looking at how we can make behavioral changes and translate those into macro health metrics and indicators. More to come on this. This study's just underway, and we will share more as the data comes in. Manasseh, I'm going to turn it back over to you to take us out.
Yeah, I thank you so much. I think we are looking at now at the next steps. I know we are time conscious, but one of the critical points I can say, we looked at what the improvements that we are able to make from October to end of April, just a mere comparison of the shift in numbers. So with that in mind, and with the study that you just alluded to in mind, our next plan is now to be able to expand. And because Rwanda so far needs about 2,000 of these second generation hotspots. So our biggest plan is to scale up and be able to have equitable distribution of this health impact. So, but that has a preliminary, which means standardizing and harmonizing the facility designs, just like we did, coming together on the table to have a proper design that is patient-oriented and sustainable. Number two is to clearly define the roles. I love the theme of this conference, the shared value, in terms of who is responsible for what, in terms of private sector, public sector, civil society, NGOs like us. How can we combine our expertise and resources to bring the best outcome that is sustainable? Then to ensure that we have accreditation and having standards that where each health facility, each health worker is going to be assessed against. We have started this, and we think this can be expanded. Also trying to look at the skills deficit and trying to address that in terms of the health workers, in terms of numbers, skills, and the profile that is needed. Then identifying the funding that is required to be able to support the whole system in a way that is very sustainable. Thank you so much.
Okay, I know we're out of time. A couple of questions came in, so I will answer those in the chat. Rosemary, over to you.
Thank you, Manasseh. Thank you, Monica, for such an amazing success story that clearly illustrate the power of creating shared value in realizing the Sustainable Development Goals. And as you said, we don't have actually any question. I only give you one question from the audience, one. And the one question, there are many, and the many questions will ask you to actually come back to attendees. So
bring
just
them on, bring them on.
Yes. Are there any opportunities for organization, private or non-private, to get involved in this initiative?
Yes, and yes, and yes. So this is again, we're trying to build an ecosystem that we want to scale up. So we're looking for funders, all sorts of organizations to bring additional health solutions, connectivity solutions, i.e. we'd like to create electronic medical records and all sorts of things like that. We need builders, we need financiers, things of that nature. Manasseh, what do you got to add to that? I know your list is long.
Yeah, my list is definitely very long. Time does not permit, but I think what we need to do is to be able to be consistent, because we have run our lessons and we have tested them against all odds. They came from the community, going back to the aspect of decentralized healthcare, going back to people-oriented and solution-oriented leadership approaches. So basically, we are taking the solution from the people who suffer the consequences of poor health, trying to scale them up. So I think all we need now is extra hands, expertise, funding, builders, and the think tank in a sense, so that we are able to scale up, define, refine and scale up the ideas we have gotten in the Bugesera district so that we have many AGNEs. The one you saw in the video, we can be able to scale to the whole of Rwanda by creating about 2,000 facilities like this with such an impact. Thank you.